Good afternoon, everyone. Since the COVID-19 outbreak has emerged in the last December 2019, many studies and trials have been conducted trying to understand or to figure out the ambiguity about of this devastating pandemic. Many questions have been answered, but there are still other questions, very important fundamental questions, we need still waiting for answer. Today, I'm going to share with you our insight about this pandemic and about this disease, and I will highlight the important points which could be potential target for a strategy which we are looking for or to combat this disease. Again, also I'll try to explain, going through the pathobiology, pathophysiology, proteomic, and metabolomic, and clinical complications of the disease. We try to show you the mechanism of this disease and the presentation, the clinical complication of the virus of this disease. Again, and I will try to again highlight on the milestones and the pathway or which could be a target for treatment. The other things here, we try to find out question and speculate for question. If to answer this question, why 15% of the patient sustain severe symptoms or present with severe disease, whereas 80% only sustain or present with mild symptoms. The pathogenesis of the COVID-19 appears to represent an interplay between the direct virally mediated damage and host immune response. Associated host immune response. This immune response, the damage could be due or secondary to a hypertense, dysregulated immune response. And why this immune response occur or happened dysregulated? Because we think there is lag in the proper or appropriate immune response. There is delay or lag, and that enable the virus to invade or to invade the lung or the tissue, and this failure or delay in the action, proper reaction at the right time, that will generate or entail overreacted, exaggerated immune reaction, which could be harmful. But before we go through that, would you please join to us for join us for virtual trip to trace the virus route, which uses a virus follow or take when attacking the human tissue. COVID-19 can gain access to the human body through one or all one of the three orifices: the mouth, nose, eye. And once the virus enter and go forward, we are expecting here the first immunological defense line, we call it epithelial immunological line, to stop the virus progressing or forward, and to stop the virus and entrapped, blocked. Obviously, this first line seems to work or act sufficiently in the young children and the healthy people and young children. And especially with children, we have very important immunological station here we call adenoid. This after 12 atrophy. This is the first immunological station, adenoid, a nasal area, and this would be the pharyngeal tonsils here, and the epithelium. The epithelium is not just only epithelial liquid; it's more than that, because they are submucosal lymphoid or lymphoid tissue here, where the antigen-presenting cells lurking there to ambush the virus on a tract. If that fail, and the virus, if this virus and sneak forward, then the virus will reach the very critical area we call the alveolus. Alveoli or alveolus. Here we have 300 million alveolus here in the lung, both lung. This alveolus is the functional unit which exchange the oxygen for the carbon dioxide, and this functional unit to work perfectly, ideally, they should be clear, transparent, and even they are designed or in the way to be away from the routine, daily, ongoing immunological check, which this could cause inflammation, because other parts of the human body could be susceptible or to ongoing inflammation. But the lung, as a very unique organ, and which require this functional alveoli to be transparent, like crystal, to be able to exchange the gas, they should be away from the usual. They need to have their own actually immunological internal immune circuit. This is internal immune circuit can protect the lung, at the same time appreciate the function what the lung do it, the lungs do it, and then remit the lung from the inflammation, unnecessary inflammation. Because if the immune system attend to the lung unnecessarily, that could cause chronic inflammation, and we'll call it fibrosis. And this is unwanted here. We'll own that. But which cell, versatile cell, can do or work in this work to do this job? And we have here very versatile, very fantastic job. We call it alveolar macrophage and resident macrophage. The resident macrophage not only protect the alveolus from the microbes or organs, but also diligently work to keep this space clear and transparent to enable to work to function well. Every day, and the average every day, the adult inhale more than 13,000 to 15,000 liters of air. This amount of air can contain myriads of the allergen, pollutants, and microbes. And that will make more burden work on the macrophage to filtrate or to clean this inhaled air, to make sure only the alveolus work well. Again, this is the in brief. This give idea about the physiology and of the lung. You see how that mean in the conclusion, the lung has its own immunological environment. what happens if when we now assume and consider the virus COVID-19 attack the lung, that will, of course, that will unusual event or accident. And COVID-19 is not like the normal, environmental allergens, or it is more than that, because we know now that the COVID-19, when sneak forward to the lung, is going to target very specific cell in the alveolus, which called alveolar type 2 cell. This is reduce the surfactant and to keep the alveolar integrity. And because this is expressed ACE2 receptors highly expressed here, so the virus get the tissue or the cells through this specific receptor ligate. But the macrophage there, guarding there, protecting, and once the virus approach this prohibited space, the macrophage will, this is the first encounter we call it, or fire engagement will happen. We expect to happen here between the macrophage and the virus. We know now the macrophage now, so here they're lurking and get the virus in ambush, and then the first things the macrophage will catch the virus and swallow the virus in the operation called phagocytosis. The phagocytosis then degrade the virus, destroy the virus into fragments, and then present the virus in its own surface. Why the macrophage do that? Because very important now, the macrophage is represent, we call it innate immunity, and we have other part of the immunity we call adaptive immunity. The adaptive immunity more specialized to react properly and specifically against the infections or the virus. So here the macrophage then try to have contact or communication with the we call the lymphocyte CD4 or helper, lymphocyte helper. And this lymphocyte helper or CD4 will represent actually the adaptive as an investigator or inspector here to represent and get the information to recognize the virus, the antigen, and then decision will be made sooner and urgently based on the information going to get it. But this is here this is interaction now. We see the virus will be fragmented and presented to the lymphocyte CD4, and the macrophage here try to then in this meeting we call it emergent meeting. Carefully and try to persuade the lymphocyte to take over and to hand the job to them. And this is very important. And 70, if their communication or ends with cooperation or coordination, then easily the scenario things will be finished and in peace. The attack will be terminated and will be contained early, peacefully and smoothly. If the communication between the macrophage and adaptive or lymphocyte system fail, and this could happen, there's still possibility in 15% of the patient for many reasons, and we're going later to know what the possible reasons for that. If that fails, then macrophage will not surround her and then proceed to take unfavorable decision to release, we call it SOS, Save Our Life, call or shout by releasing the interleukins and mediator, which call all the various components in the immune system to move and to recruit them to attend to the inflamed area here of the lung. Let us see now that we first assume, and we hope also that this what happened then. And this we hope the communication, because we prefer all the first scenario, the communication between the macrophage and lymphocyte CD4 will be productive and come up with decision to hand over the work, the job, to the adaptive immune system, which is more specialized in fighting the viruses. But there are conditions here usually rule this emergent conference between the macrophage and TCD4. First, when macrophage present the antigen, does not just only present the viral antigen or peptides. It presented next to 1,000. For example, if the macrophage present 40 peptides belong to that virus, there are 100,000. This is an HIV, I give an example. So it is a mixture of that, and that requires more work from the CD4 to scan and to find the antigen, to recognize that viral antigen. The other things, this is a scanning, is a time and energy consuming process. And unfortunately, there is still possibility all the time, there is risk the engagement between CD4 and macrophage to end without result. So it is hard. It is very critical point here, and this is turning point in the conflict. Very important to pass this information to lymphocyte. And if the lymphocyte now scan the information and recognize the antigen, the molecular design of the antigen, then there are still 3 more conditions. Intermediate steps. Step should be, verified and approved. Like what? To pass this decision to the rest of the adaptive immune system, the other lymphocytes still in the body, because they are waiting for the signal. So first, all the rest of, because this is the representative, this negotiator should issue the signal, and the rest of the immune, they should express, we call co-stimulatory receptors, we call CD28, to receive the message from the negotiator and with approval. The second thing also there is for the adaptive immune system and lymphocyte, subgroup of lymphocyte to be recruited and moved to they should they need to stimulate it by the certain amount of cytokines, which we usually released from the macrophage and from this CD4, lymphocyte CD4. This is the second condition. The third condition also, the lymphocyte, they want to make sure the macrophage or the other part of the negotiation, now they recognize and they know the virus, they recognize the virus antigen, and when they bring here, there will be sort of coordination. Every party, they know their job. Why this part of the negotiation or communication between the heart, because the lymphocyte or the adaptive immune system, they want to make sure when they attend or they recruit their groups and come to the lung, they will not cause we call it self damage. They make sure they specifically because and they are trained for that. Most of the lymphocyte they have this experience. They were trained in a thymus, and they have this experience, and they want to make sure they will be trained and they will not cause damage to local tissue, only to target the virus. Again, that will be good news of the approval and verification, and the decision will be taken, and the lymphocyte subgroups of lymphocyte will be recruited to the lung, and we really will know the patient who in the mass cytometry, the patient who had the lung, they succeeded to recruit the lymphocyte, then that gave protective effect. They sustained, and that's good. So recruiting the lymphocyte will be. But if there is delay, and you remember now, in the meantime, while I'm talking in this scenario, the virus already maybe invaded the whole lung. And the virus exploit this delay and lag in communication or making decision. This should be made in the window of the time. The virus then invaded or multiplied in the lung. And moreover, further, maybe the virus even now utilize or take the privilege of the lung as a tissue with because the perfusion is high, the vascular heal is very extensive, and take free transportation to the remote organs, to the lung, to the kidney, or the heart, or the vessels, or they already may be infiltrated, and this will be beginning of the trouble, or would be ominous sign if this happens. Anyway, the macrophage assess the condition. If the condition fail again, then the macrophage they will find themselves obliged to take another option, or they follow other choice option called the option or choice of the necessity, and call randomly SOS the whole human, the multiple various, the various component of the immune system to come to the lung, to save the lung, to save the organ. And what will happen then? Unfortunately, this is the choice of necessity. But this decision, yes, is necessary because now the bacteria is hesitant to take decision, and the virus already multiplied, and now, well, what's the option then? What's required? Then, the whole, the macrophage will, we call it activate or ignite, activate I call the fire line. It is more aggressive, and the macrophage now will convert to change itself to pro-inflammatory type and produce interleukins 1 and TNF, interleukin 6, chemokines, all that, and will change, and then see what will happen, what the consequences here will be. Then the classical monocyte will be called and moved from the spleen, from the bone marrow, peripheral blood, and will come. This is pro-inflammatory. The neutrophil will also, blood-borne neutrophil come, and here turns endothelial infiltration, migration will come and infiltrate the tissue or here in the lung, and use we call it vascular adhesive cell molecule as escapes to infiltrate. The here we see the virus here destroyed some cells already, the first thing, and we start to degrade the epithelial cell. Already here we see the leakage because the capillary here started leaking fluids, and this is flooding here, tissue flooding. We could see, and what happened here, the microthrombosis, because the platelets will be activated, also express 147, we call CD47, and this could be attached to the virus, and could be also this is interact with the monocyte, and to add more inflammation. Platelets, we think the complement will be activated, platelets and monocyte, and flooding, edema, flooding, leakage, inflammation, destruction. Okay, what that is? What's that? Simply, this is cytokine storm. This is the cytokine storm now. Oh, so cytokine storm now. You see here now. This is and this is the outcome of the decision. But this is necessary, but could be catastrophic decision. And this, what we call the cytokine storm. Cytokine storm happen in 5%, maybe 15% of the patient who have COVID-19. Majority of them, they could develop, sadly, cytokine storm, which could be, or most likely be, life-threatening condition, which require here mechanical ventilation. But I can see how the mechanical ventilation will work here. See here now, this is the equivalent actually to ARDS, where the lung will be congested by fluids and flooded by flooding here fluids. And because now we don't have functional alveolus to work, to receive, to take that, to uptake that oxygen. So I cannot see how the mechanical ventilation will work here. Yeah, and for this reason, most of these people, they maybe they could not, pass or survive if the critical of this is ARDS develop. If they develop this, histologically here in histopathology, we can see here how the virus cause here diffuse alveolar damage, destruction here, and here the thrombosis in the arteriole and a small artery, pulmonary artery here, and you see how most of the infiltrated by the inflammatory cell, the immune system here now. This has become now like the battle, theater of battle. This is a theater of battle. Here you can see the electron microscope here. Show us the virus here in an occlusion body, which is an indicator of the virus, and peritubal capillary and glomerular here in the kidney here. And again, this is the neutrophil here, and inflammatory cell here in the endothelium, and all the endothelial cell degraded, and apoptosis happen here, apoptosis, and and this, this is respiratory failure. This sign is ominous sign. It's not good sign actually to see here. Then yeah, and well, this is the worst scenario we can see here. The worst scenario we can see, and unfortunately, still 10% of the patient still develop or progress to this. I mean, catastrophic result, and yeah, devastating condition. The next, but the question here is the cytokine storm confined only to the lung? Of course not. The cytokine storm is general inflammatory phenomenon which actually could affect the whole organs. We see it in the lung, very clear, evident, but in the meantime, while we see this change in the lung, the another inflammation is going there in other organs. For this reason, we know that explains why many patients then their condition will get worse, and end with multi-organ failure, we call it, because this is the cytokines could cause, and the sepsis multi-organ failure. We know that. We see that not only with the COVID-19, with other medical condition or viral infection or bacterial infection even. So the next vital organ could be affected or damaged by COVID-19 is the heart. The heart, the mechanism of the damage could be due to the, we call it pseudo infraction, and with intact coronary arteries, or stress cardiomyopathy, hypoxic cardiomyopathy, viral myocarditis, and it could cause immunologically hypersensitivity mediated damage, or hypoxic right heart strain, because the bone, if the respiratory failure could cause also heart failure reflected, or pulmonary embolism. This is the inflammation features of the heart damage. But there is another reason here in the heart. This is specific related to the heart, which could affect in the heart a part of the inflammation. We call the imbalance between the RAS and MAS pathways. So you see here RAS, renin, angiotensin, aldosterone. This is pathway which this cause vasoconstrictions, cell proliferation, and fibrosis, hypertrophy, fibrosis. That pathway, the RAS, and this is the MAS. When the virus, because the virus target the angiotensin converting enzyme 2, so the virus could cause an activation of this receptors, and that will tip off the scale and the balance towards the angiotensin 2 pathway, RAS, and that pathway effect will be potentiated, and that will cause the vasoconstrictions, high blood pressure, and we know that. We have seen patients who are healthy, but because this imbalance in the RAS and MAS, that the patient attended with high blood pressure, and some of them could easily, that could lead to hemodynamic instability, and that again explain why some patients deteriorate quickly. This is regardless of the inflammation. Well, when in the heart here, in regard to the heart, we have now, actually, unfortunately, bad news came from Germany. Recently, in the last 3 weeks, a study has chased or followed 100 patients in Frankfurt hospital, and this patient recovered from COVID-19, but they chased them with cardiac MRI. Majority of the patient, 78 of the patient, showed the signs or degree of the cardiac damage. COVID-19 induced cardiac inflammation or damage, regardless of the pre-existent medical condition or severity of the disease. I mean, even the patient who, developed before they had mild or symptoms, they still, some of them sustain now cardiac damage. This news really raises concern, and in our turn here, we need to raise here the flag, and we think this patient, it's worth it to follow this patient up, because we know the heart, the myocardium is troublesome. There are many virus. They have few virus. Not many. Herpes virus, Coxsackie virus, parvo virus, and enterovirus. And this virus, they have specific tropism toward the heart. But we don't know until this study now, and it was not known. The coronavirus has this strong tropism toward the myocardium, to the heart. And in this case, well, we need to follow this patient properly, because 27 from our experience from other viral myocarditis infection, they could progress to heart failure. We need to follow them even with endomyocardial biopsy sometimes, or cardiac combined with cardiac MRI, and to differentiate first between the myocarditis with lymphocyte infiltration and viral particles, or from the patient who have just myocardial infiltration without viral particles. And you see here the cardiac MRI is showed pericardial effusion, and there is here inflammation in the myocardial inflammation. Well, why? It's very important, because this inflammation could, to prevent the sudden death and ventricular remodeling. It's very important to stop and to prevent the two issue. The two issue. This is the heart. The other complication of COVID-19, the COVID-19 could cause renal injury, and the mechanism is immune complex disease, antigen and antibody. The goal, will be airborne, bloodborne, and they will go and deposit in the vascular system of the kidney, capillary, and that stimulates inflammation, glomerulonephritis, vasculitis, and renal failure. Other patients, they could have pulmonary embolism, and we know the patient with COVID-19, they demonstrate hypercoagulable or coagulation. And the reason, because the inflammation stimulates the heart, the liver, and the liver make more fibrinogen, factor 8, D-dimer, and status, all that together endothelial damage, and that will make the patient more susceptible to the thrombosis, microthrombosis or visible and evident thrombosis. That cause many cases have been reported. There are many cases reported: paradoxical stroke, ischemic limb, pulmonary embolism. And why? and this happened actually. There are many mechanisms of the coagulation here, endothelial damage, and we'll show you later how the according based on the glutamate and metabolomic how this an infection could disturb the many molecules and pathways and disturb that, and this will lead to this extensive damage. From the beginning, we expected that COVID-19 would stimulate the all known hypersensitivity, immunological hypersensitivity types or reaction types, because we have type 1, type 2, type 3. The type 1 is antibody immunoglobulin E mediated, and type 2 complement, and antigen, type 3 antigen antibody, type 4 delayed immunological delay reaction, which lymphocyte. And actually, all this, the 4 types of immunological hypersensitivity have been noticed or observed in this pandemic, in this disease. Next, let us go next to now. We understand now the mechanism, how the virus invade the humans, the tissue, and the clinical complications. But in the molecular level, well, we need to cross the information, knowledge, and see what happened in the molecular level. 3-4 studies in China and the UK, Germany, their cooperation. We call it very sophisticated and advanced study. We call it proteomic and metabolomic data. This is to check in the serum of the patient with COVID-19. They checked on 100 patients. These patients, some of them had severe conditions, some of them have had mild, just to compare. And we know the human serum contain maybe 10 billion different molecules, proteins, the smallest cytokines and the largest albumin. And what they found here, actually, to see if there is correlation between, to find out if there is correlation between the clinical symptoms and the molecular change or alteration, virus-induced molecular alteration. You remember when we said in the 15% of the cases, the macrophage is obliged to choose the fire line, the aggressive. See here how that happened. Actually, the macrophage interact with we call it LPS, lipopolysaccharide here, and LPS. This is a key look interaction as molecular will interact with TLR4, toll-like, we call it receptor 4, and CD14, this receptor here in the macrophage. And this interaction, this is the way how the macrophage catch or ambush or catch the virus. And that ignite signal, and the signal ignite downstream signaling and go through this, I call it flame line, because this is really like the fire, and this is fuel fire. This is fuel the inflammation. And this line here go and the purpose, the aim, to trigger nuclear factor kappa B. This is the key of the inflammation, this factor. And that will stimulate the body, to the cells, to produce the interleukins 6, TNF, 1, all that from the. Okay. Now, what will happen? We know now that, and we know that that will fuel and this production of that lead to increased level of interleukin 6. Well, have the patient with severe really showed or high level? Yes. And the proteomic, yes. That means that, again, that confirm, yes, the worst scenario followed this track. Did they show CD14, high CD14 level? Yes. And they showed LBS. That means, that tell us from here, the fire. Here was, the proteomic showed, here was there, something happened there. Smell, it's powder of there is fire. This is show there is fire. There's something very serious happened here, occurred here. Something very, this is what fire, the result. Didn't see the battle, but we witnessed the battle. But this show you, if you go through and you find the remaining of the Rix and suction, and you come to a conclusion there is something horrible. There's something very serious happened here, and this is exactly what we're trying to find in proteomic world. The outcome, the result of what happened. CD4 is not everything. Okay, then we'll go. Then interleukin 6 then increase, and most of the patients will, we know that they had interleukin 6, the level is high, and two groups at the beginning. If you remember, in the last 3 months, one of the groups tried to, they said, well, interleukin 6 antagonist, like tocilizumab trial, in the beginning, they said they could stop the inflammation. We need to block this pathway. We need to stop the inflammation. And unfortunately, this is not help. They gave unwanted result, and the inflammation increased. The other group tried to stop in this level, to block the, which medication act in this level, myeloid D88 is the statins. And some trials say, we'll give statins for the viral, and well, we can stop that inflammation. And unfortunately, again, the patient get worse, the inflammation get worse, because an experiment for that, maybe alternative compensatory alternative pathway has been activated. Even if you block that, because eventually macrophage will determined to shout now. Whatever, you cannot stop it. That brings to the situation. Then what will happen then here, anyway, now we know the outcome of that, the macrophage now you cannot, in this way, you can't stop. We tried it, some teams, research team in America, and this use statins to stop that. Some of them is tocilizumab, interleukin 6 antagonist to stop that. Unfortunately, both of them failed trials. We cannot now stop that. And if you try to stop this pathway, that will, because macrophage knows better, that will give unwanted, opposite result and outcome, and we make things worse. And the flame plays more, and flame plays more. Okay, then the interleukin 6 here go to the then activate the liver, and the liver will produce we call it acute phase protein phase, acute phase proteins, CRP, and we know the patients who are ill, they have CRP, it's high. Ferritin is high. This is, once the interleukin activate the liver, that will happen actually. And the liver show this protein degradation is exhausted, and therefore actually lose the capacity of the detoxification. This is another issue. And again, well, that will be, this is the features of this disease. And that activate the liver to stimulate the liver to produce more coagulation factors, and we know that, we mentioned that. And other things, for 14 proteins of which involved in platelet degeneration are downregulated, and that explains why maybe the platelets tend to aggregate more, because the metabolism of the platelets get disturbed, and platelets interact, because 50% of the platelets are produced in the lung, and there in the lung injury could stimulate the platelets to interact, or especially the sensitive platelets now, fragile platelets, to interact with inflammatory monocyte, and that will produce more inflammation and add more to the cytokine storm. And this is exactly what happened. We see. We know other things that proteomic and metabolism showed. You know how much there is really close correlation between the macrophage. You know, this is versatile immune cell. We start to function and the lipid metabolism. We know that from our experience with other viruses. Many studies have been done for that. And even they start to talk about that there is a branch of the immune metabolism. And we have in the COVID-19 100 lipids level get modified or dysregulated, and that affect directly on the macrophage function. And maybe this is make the fan exhausted already and make the not prepared to work properly. But patient to interact with or to communicate with lymphocyte. Remember in the beginning, and we showed here and showed Abu Lipo 1A1. This is one of the lipids which related to the cholesterol metabolism. It was reported or observed when the patient just present with mild symptoms. When they have transitioned from mild, when they deteriorate quickly within hours, they found that will be coincide or concomitant with apolipo, lipid A1 decrease. Yeah. So again, yes, 50 more. Moreover, further, 50 out 93 proteins are modulated, changed. These proteins belong to the complement and macrophage and platelets that way. What does that mean? That means the proteomic showed us, gave us idea about this mess and this regression in the metabolism and the molecular level. The question here: are the metabolic or this molecular alteration correlated with the S? We can see now that confirm. Now we are on the right way. We understand. We understand what's going there. What's happening there? What happened there? So there is now, we conclude there is correlation between the molecular alteration and the clinical complications. That means we, to some extent, not fully, we understand more now about the pathophysiology and pathobiology about this disease. Okay, where that will lead us to treatment. But the question here, well, with this so far, with this understanding, do we have what the current treatment we have? And the current treatment we have, are these treatment or those treatment satisfactory? Let us go through again what we have here. We have dexamethasone. The dexamethasone in the last 2 months, actually, in UK, this has been introduced as a part of the COVID-19 management after trial has been conducted here on thousands of patients. And they said, well, they think that this dexamethasone could reduce the mortality if we use it for the patient who need supplemental oxygen or intensive care unit, mechanical ventilation only, but not. And you remember, yes, it is not advisable to give the dexamethasone in the first 5 days because you need to give the immune system a chance, otherwise we will suppress blindly. And they think that dexamethasone could reduce the mortality, relative mortality, not the absolute. The absolute 3%, but not 15%. But this is if there is no certainty about that still. And I agree. Well, why? Because if you remember, if you know actually, most of the patients come to the hospital, Many patients, they could suffer from the COPD, asthma, septic shock, adrenal insufficiency. And if the patient has one of these comorbidities, the dexamethasone here anyway will be a life-saving treatment, regardless of the COVID-19 or not. So maybe the benefit which have been gained from dexamethasone, the patient get the benefit not because the dexamethasone acted or worked in the COVID-19, but because the dexamethasone treated the other serious comorbidity like asthma or COPD, adrenal insufficiency or septic shock, and that interpret why some patients get benefit, and this patient anyway they will need dexamethasone regardless if they have dexamethasone or not. We agree with that. Then we come to the next indication, remdesivir. This is medication. This also this antiviral. This is for the mild patient who has been prioritized for the patient with mild symptoms, but not for the patient on the mechanical ventilation or need high oxygen supplement. There is still no evidence will show or confirm that will improve the clinical symptoms or reduce the mortality. Interleukin-6 antagonist, like tocilizumab, unfortunately has no role in this treatment because blindly they could suppress, but as we see, hydroxychloroquine and azithromycin, well, this medication should not, and most people don't get this medication, and this is very risky because the hydroxychloroquine, well, the beginning they thought, well, in the vitro in the lab when we put the hydroxychloroquine in the virus, they could inhibit the virus. This is something, but within the body, well, the thing is not simple like that in vivo or in the human tissue. So for this reason, and it could be toxic and risky because why? You know now why we have many patients who have already they could sustain myocarditis or inflammation in the heart, and this medication like azithromycin and both of them they could prolong the QT and the effect, they have specific effect at first, effect in the heart, wrong QT, that could lead to arrhythmia and cardiac arrest. And this is true. Many reports from different hospitals, they say the patient who had this combination, more cardiac arrest have been reported. So it is not really, there is no evidence there is benefit, and it could be harmful. Favipiravir, has been tried in South Asia, and this is, they said, well, has the recovery and increase, but this is for mild cases. Anyway, they will prove. Convalescent antibodies, if this has been given, the serum taken antibodies, if they have been taken from the given to the patient in the first 72 hours, they could hasten or increase the clearness of the virus. But there is no, again, any evidence this could affect the mortality or unfortunately, the lack of evidence. And like a transfusion reaction, symptoms happened. There are side effects of this. Interferon beta actually has been also, this is suggested too, and we tried before, and MERS and other inhalation to increase, to stimulate the immune system, and also has immunomodulation effect. And some try to develop like in the spray. But again, there is uncertainty, no proof it is effective. There is no solid evidence this interferon has effect. And again, Iranian study has been conducted and claimed they get benefit, but with reviewing this study, the methodologic limitation actually reduced the confidence in the study. So, well, because there is issue on the methodologic conduct. So far, then, there is no medication proved to be effective against COVID-19. It's very sad. Unfortunately, there is no medication so far proved to be effective against COVID-19. So our perspective, what we think here, actually, we are surgeon, we're still speculating and research multiple molecules pathway might be potential targets for that, and we are still we researching, we are speculating multiple molecules and pathway which might be potential target for multifaceted strategy. With that, could modulate the disorders induced COVID-19. And the way how we are thinking to folks, and first, remember, I talk about here, remember, and the first line, epithelial, this is very important. If we need to understand more, to focus more on this, and we entrap or stop the virus in this level before, that would be great. And we have actually potential here, and we have potential molecules could act on this level. And to stop the virus to progress and to minimize the chance of reaching this area. There are many, actually. There are. Yeah. And especially remember the adenoid here, the lymphoid tissue, submucosal lymphoid tissue here, and this is all could stop the virus. Other things here, we have the again when it's come to the next stage, the macrophage Remember, we showed that we need to pay more attention to the macrophage and the macrophage metabolism is to resuscitate the macrophage and to resuscitate the macrophage, because we, from the explanation, remember the physiology of the macrophage has boredom. They are boredom work in the macrophage, and the macrophage use the MHC2 to present the and proofreading, this is model we call it, to the CD4. This MHC could be as expressed that the quality is different from individual to individual, and that explains why sometimes the macrophage cannot succeed and the CD4 cannot sustain and in this position, and this could be, we need to know why this could be as a cause of one of the failure. If you know human leukocyte antigen, which is encoded by this, and there is in the human, this is the most variable region or area region in the human genome. Means, they are different groups, different people, they have different quality or design of C. And that explains why some people, they could have MHC which designed properly to work sharply and sufficiently to present and catch the, or some they don't have. So, and this is need now, we're thinking to do analysis to find the different group, the genetic analysis to find who are there and what the type of the make the patient susceptible. Because now we think there are some alleles and could contribute, certain alleles contribute to render some individual susceptible to this disease. And the other things here, activation, TCR, the 100 trillion, the lymphocyte it has variability, we call recombination, to express the variation of the expressing different coding and encoding TCR unlimited, but they estimated more than 100 trillion variation of that. But so that it is very, but sometimes this atomic, because lymphocyte, that depends on the lymphocyte, and could be this is naive or not experienced how to deal with to be patient in this interaction, to be experienced to command this communication. For this reason, we think also there is a drawback here, limitation. You know, the lymphocyte they get their training in the thymus, and the thymus become regress and atrophy. In the age 18 start to regress, and in age 65 there is little trace of so there is no anymore in 65, very little chance that for this lymphocyte T to get more contact or input to get input to the thymus, what they call central control of the thymus. And because no master, no supervising, no teaching, maybe the virus will, this is lymphocyte, then in 65, they don't have the experience, a proper experience which is required to command, to do this inspection and investigation role. And we need to do, we call this, and now in transcriptome, we call it single cell transcriptome. We could catch and one of the cell, and this to interrogate it, to find what happened behind the doors when the what negotiation, what happened, where the defect was, the issue, and the interrogate and to recollect the black box information from that meeting or records. And this technique is called the single cell transcriptome. Yes. Other things here, when it comes to the cytokine storm here, and we still have chance. You see that this is a nuclear factor. This is the key. This orchestra the storm with interleukin-6. We know we cannot now because this is compensatory, but could be activated. But we need to coax and convince and persuade the macrophage not provide a support, other support, and not calling for unnecessary reaction. And if this happens still, so when the branch, there's monocyte here come, the monocyte, this one could become, this is classical, this is non-classical, still could be confirmed to replenish the resident macrophage and to take the role. We could get this domesticated, to be taught to be calm and trained to do the job in the right way. You see, the interaction. And there is other factors which could work here, which decrease the decrease the vascular leakage and thrombosis. There are many targets actually. Here we could intervene this level to alleviate the inflammation of the heart and the myocardium. And in this level, as I explained to you, some research teams tried to use the statins to block this level, and when they failed, this gave unwanted result. And some tried to use this here interleukin 6 antagonist, and unfortunately not will come with any, as you see. But we still we have more choices. We have more to investigate and to find the cause of the genetic variation between the groups, and the patient who sustain severe disease and the one who present with mild symptoms. Single nucleated polymorphism, SNP, again, to find differences. This could be the cause. The whole genome studies and epigenetic, and this is also to study how the other environmental factors we have in our mind. Some factors could affect in the way we call DNA methylation, could activate certain or deactivate certain genes, and that affect eventually in the gene work and the cell or function. And these factors, well, we call the epigenetic interaction between the genes and the environmental factors. So this is our perspective, And please, if you have any questions, we can receive any question regarding to this serious condition.